Hello there. I'm Dr. Carl Pesta, and I would like to thank you for considering weight loss surgery. This is something that is going to change your life in ways that you are not even thinking of. I'd like to tell you first a little bit about myself and our program, then take you through a quick seminar that talks about the benefits of bariatric surgery, the disease of morbid obesity, and hopefully answer some of the questions that you have. I have been a bariatric surgeon since 2003, over 20 years of experience, over 10,000 surgeries, and I want you to know you've come to a great place. I'm very passionate about bariatric surgery and the way it changes my patients' lives. I have the benefit of giving talks around the world on bariatric surgery. I am a pioneer in different ways to make bariatric surgery safer. I work collaboratively with colleagues around the state and around the world to make sure that you are getting the best experience possible. Here at McLaren Macomb Hospital at the Bariatric Surgery Institute, we take great pride in taking care of you, holding your hand along the process, and making sure that you're prepared for bariatric surgery with all of your questions answered, all the support that you need, and making sure that we have everything you need to have great success. Let me start my presentation for you. It's a slideshow. I hope to take about 25 minutes to a half hour to get through this. And let's see how we do this. Technology is often challenging, but I think I've got it going here. All right, here we are. McLaren Macomb, Bariatric Surgery Institute, weight loss surgery, a permanent solution for obesity. This is me. Usually you'll see me in a bow tie. I was working last night overnight and still in my scrubs, but this is how you'll see me the morning of surgery. Here's how, with the bow tie, you'll see me in the office. Now, we are a center of excellence, what is now called an accredited center in bariatric surgery, which means we've gone through all types of training to be sure that we take great care of our patients, from sensitivity training, which is rolled out through the entire hospital. So people treat you with dignity and respect. Volume and credentials, I've told you the volume of surgeries that I've performed. And of course, the more you do, the better you are. We educate our staff, not only our office staff, but our hospital staff, our emergency staff, from everyone that you may come in contact with the hospital. They're aware of our program and how strong it is. We've got great administrative support, meaning if there's something I need that I can do to make your surgery safer or your hospital stay better, we've got great administrative support. And then we use standards and pathways. We find that doing the same thing over and over is what gives us the best results. In fact, we have some of the safest surgeries in all of the state. I want to introduce the team. Of course, we couldn't do it without the people that we work with. Jenny Kay, or Jenny Kasperzik, is our metabolic and bariatric program coordinator. She has been in the field of bariatric surgery for over a decade. She's also a dietitian and is a great resource and has great knowledge, but also is really in charge and keeps the wheels and the motor running. So you'll be working with her quite a bit. In my office are two fabulous ladies, Megan Mathis, our office coordinator and manager, and Harley Voorhees, who's our assistant extraordinaire. With these three fabulous people, we're able to get you through the process, work with your insurance, and get you prepared for surgery in order to move things forward as quickly as possible. I know once you've made it to this step, you are really ready to have surgery tomorrow. We find that we've kind of streamlined the process so that you are ready to go as soon as possible. So let's talk a little bit about the disease of morbid obesity. It is generally 100 pounds over your ideal body weight, but we also use something called the body mass index. And I'll go through this a little bit more, but here's the criteria of healthy weight up to morbid obesity. Now, if you're really good at math, you can calculate your BMI, taking your weight in kilograms divided by your height in meters squared. I got a little easier solution for you. Here's a simple chart here. And what you do, I'll try to move my video out of the way, is basically you take your height across the top, you drop down to your weight along the left side. It's a rough estimate, but there's all kinds of apps on the computer now or your phone that can find your body mass index. And we see a healthy weight is 18 to 25, overweight is 25 to 30, obese is 30 to 35, and severe obesity is 35 to 40, and then morbid obesity is greater than 40. We're going to talk a little bit about who qualifies for bariatric surgery in all of these different categories. Now, recently, the BMI category of 30 to 35 has been added, especially for Asian descent or in some insurances, if you have diabetes. And we'll work with you on that. But for now, the major criteria is BMI of 35 and above with comorbid conditions, which are like high blood pressure, diabetes, and I'll go through this a little bit more, or a BMI of over 40. So it's important you know where you are in this, what is your BMI, and then we can talk with you about who may qualify for surgery. And if you don't qualify for surgery, what other options do we have? Now, we know there's an economic impact of obesity. Most of us are doing this for our health. We want to get back to our lives, but it also impacts a lot. The cost of healthcare in the United States continues to grow. If you are in these higher BMI categories, you're spending 50% more on your medical spending and 80% more than a normal weight individual on your prescriptions. So we're throwing money away, and we can get that money back to you. There's over 80 million individuals in the United States that are considered obese. And morbid obesity takes up about a third of all the appointments at our family medicine or our internist office. But what a lot of people don't realize is it's a deadly disease. It's the second leading cause of preventable death behind cigarette smoking. Approximately 400,000 excess deaths per year. And people who are in these higher BMI categories have a shorter lifespan by about 10 to 15 years. And these are our golden years when we want to play with our grandchildren. We want to go on vacation. We want to enjoy our retirement. And that's why it's so important to address this now. So what causes morbid obesity? Well, it's multifactorial, genetic component, environmental component, behavioral component. For instance, in the environment in which we live, between 1970 and 1980, the number of fast food outlets in the United States rose from 30,000 to 140,000. In 2015, there's about 222,000. In 2023, over 600,000 fast food restaurants. And we know it's just become a way of life. We're hungry after work. We stop in, we grab a meal that could be anywhere from 800 to 1,000 calories, and we finish it within 10, 15 minutes. That's just not how our body is prepared to handle food. I throw in some humor here. The evolution of obesity, you see him at Tim Hortons cup on the far right. Now, there is important things about this slide other than the Tim Hortons cup. It goes back to the hormones that our body has developed in order to control our hunger and our satiety, which means that it's the word for us being full. Now, our lifestyle in the past, you've heard your grandparents talk about walking to school uphill both ways. Now we're driving everywhere. Hopefully it doesn't get to like this where we take the dog for a walk or just let the dog take the dog for a walk. It's really important we incorporate all these things into our program as far as nutrition, physical activity, behavior, modification. And we're going to help you along that way. One thing we're seeing is an increase in the rise of adolescent obesity. This poor kid, he has no chance at a healthy lifestyle if he keeps this up. We are looking at introducing adolescent surgery to our program. It's much needed. The sooner we can impact the disease of obesity, the better chance we have at our patients having a longer, healthier life. For now, our age is 18 as the starting age, but we'll be looking to go down to as early as age 14. Now, why is the excess weight so unhealthy for us? Well, it interferes with our body's organs. It reduces our life expectancy, as I mentioned, and it increases the risk for one of 34 more comorbidities. I'm going to describe some of those here. These are some of the comorbidities that are affected by morbid obesity. And the percentages underneath basically are the percentage of people who have these different comorbid conditions if they are morbidly obese. Sleep apnea, 60%, high blood pressure, 25 to 55%. You can see the numbers here, diabetes. And what the problem is that, when we go to our family doctor's office and we start to notice our blood pressure creeping up or our blood sugars keep creeping up, or we're starting to have a leaky bladder or gallbladder goes bad, or we're having heartburn, our family doctors, because they don't have other tools, put Band-Aids on these. They'll put you on a blood pressure pill. They'll put you on some medication for your arthritis, start you on a cholesterol medication, some hormones for your menstrual irregularities, the purple pill for your reflux. And what we're doing, like I said, is just putting Band-Aids on all the problems. But if we can treat the central problem of morbid obesity, you'll see later slides how almost all of these things go away. Sounds too true to be, or sounds too good to be true, but it is surprising to see. And you can check out our Facebook page, see some of our testimonials about how patients were on all these medications. Now they're off of all their medications. They were in a scooter, now they're walking. It's really impactful. And again, I'm excited that you're here learning more about it. Now, different weight loss strategies, we've tried these things: dietary intervention, physical activity, behavior modification, even medications. Some of the injectable medications, maybe some of you have been on, but realize that there's some side effects or that you don't want to be on it for the rest of your life. And then we know that weight loss surgery, through all types of research, is the most effective approach for long-term weight loss. And we'll cover a lot of these things when you come meet with us in the office. So why surgery? Diet and exercise only work in 1 in 20 people who are morbidly obese. That's 5%. And I know if you had a life-threatening infection and your physician said, I'm going to give you an antibiotic that works 5% of the time, you'd say you're crazy. Morbid obesity is a life-threatening disease, and diet and exercise only work in 1 in 20 people who are morbidly obese. We know that surgery is safe and effective. As I said, we've got one of the safest programs in the state. I've been doing this for a long time. I'm going to show you how weight loss surgery is safer than even having your gallbladder out. And if your family doctor said you need to have your gallbladder out, you'd probably go see a surgeon and schedule without thinking about the risk. Bariatric surgery is very safe. And an interesting study done in Canada years ago looked at the risks of having surgery versus not having surgery. It looked at 22,000 patients, where 11,000 patients had surgery and 11,000 didn't. And at the end of the 10-year study, only 6% had passed away in the surgery group, and 33% had passed away in the people who did not choose surgery, because the disease of morbid obesity is so deadly. So we encourage you to consider and continue on the path of seeking bariatric surgery. We know that it reduces the risk of death from multiple different aspects: heart disease and those types of things. Now, this is what I was talking about. Bariatric surgery mortality rate, less than 1 in 1,000. Gallbladder surgery, higher. If you had your hip replaced, you were 10 times higher mortality risk than bariatric surgery. And heart disease with a heart bypass is significantly higher. Very safe operations. Some of the most common operations I'm going to talk to you about here, especially the sleeve gastrectomy and the gastric bypass. The gastric band is a good option for some people, but we're most often performing the gastric bypass and the gastric sleeve. There's some other options I'll talk about shortly as well. Now, it's important that we choose the right operation. Each patient is different. So when you come to us, I want you to think about a couple of different things. Your BMI and higher risk medical conditions like diabetes or reflux can impact what surgery may be better for you. So choosing the right operation the first time prevents the need for future surgery. I do a lot of revisional surgery as well. So people will come to me from many other programs, other parts of the state or the country, actually even around the world. And it's because they chose the wrong operation the first time. We're going to help guide you through which operation is the best for you. Ultimately, it is your decision, but we want to be there to help you make that decision. The adjustable gastric band was very popular decades ago, and it's still appropriate for some patients. It's where we put a band around the upper part of the stomach to create a small pouch above that band. It is adjustable, so we adjust that by adding fluid to the band. You have to poke a needle through the skin into the port, and then we can adjust it if you are still hungry and searching out for food. We adjust it until you hit that green zone where you get full fast, small meals satisfy you, and you maintain your weight or lose weight at appropriate amount. Then some people say, well, tighten that sucker up. I don't want to eat anything. Of course, that's unsafe, and we don't necessarily do that, but we'll help guide you. Now, again, this is for lower BMI patients, maybe 30 to 35. There's no stapling involved of the stomach, so that's why some people like it. There's no cutting of the stomach or rerouting or anything like that. You go home the same day. It is reversible. But the disadvantages are it is an implanted medical device. Adjustments are needed regularly, very frequent follow-up monthly in the office. It's a slower and less weight loss. Risks of any operation include infection, nausea, vomiting. The bands could slip or erode into the stomach, could cause a blockage or need for reoperation. It is probably the most common revisional surgery we do is taking out the band and creating a different operation. There's something to keep in mind. The sleeve gastrectomy really had its boom in 2008. Used to be the first part of a two-part operation. There's some basic anatomy, the esophagus, stomach, large intestine, small intestine. Now, this is your normal stomach, and it takes a large amount of food or fluid to fill your stomach. Then it starts going down the small intestine. You see where the digestive enzymes come in and turns the food green. Now, during your sleeve operation, we take a tube about the size of, I don't know, your finger, and we staple along and remove about 80% of the stomach. So that creates a much smaller volume that we need to eat to make us feel full. But it also removes that part of the stomach that creates the hunger hormone called ghrelin. And removing that hunger hormone, a lot of people after having their sleep will say that they don't feel hungry anymore. They have to remind themselves that it's time to eat. So you see a much smaller volume of food, stretch the stomach, make you feel full. And then there's the normal pathway of the digestion. Now, the advantages. There's a rapid initial weight loss. We lose the majority of our weight in the first year. There's no dumping syndrome. I'll explain that later. It does reduce the hunger hormone ghrelin. There's no bypass, no malabsorption, so less risk of nutritional deficiencies, even though that's very low in bypass. Short hospital stay, maybe ideal for patients who have a lot of adhesions inside their abdomen, or they've got Crohn's disease or cirrhosis. We can still put a scope down the mouth and look into the small intestine like we could before. Disadvantages are stomach stapling, and it's certainly non-reversible. We take out that part of the stomach and it's sent off to the pathologist. But we've found that reversing bariatric operations, there's really no need for that in the majority of patients. Let's talk about the gastric bypass. That's the most common operation lifelong. It's kind of the gold standard as far as weight loss surgery goes. It's done laparoscopically or robotically through 5 to 6 small incisions. And I'll talk a little bit about robotic surgery. Robotic surgery is a technology that has advanced. I still do the operation, but just with the help of the robotic system. Laparoscopic surgery is still performed for gastric bypass, gastric sleeve as well. Now we start with the gastric bypass by dividing the upper corner of the stomach, which is the non-stretchy part of the stomach, and that's the gastric pouch, or our new small stomach. We then go downstream and we divide the intestine. We bring the lower part of the intestine up to the gastric pouch and connect it there, then connect the lower part to itself down below. So now you see the food takes its normal path. It goes into the small pouch and then into the small intestine. The digestive enzymes go the opposite route, and then they meet down below. So the first part where you see the blue, there's no absorption. And on the green, there's no food passing through there. It's not until they meet down below that you start the normal digestion process. And so that's why it's a bypass, gastric bypass. Gastric meaning stomach. We're bypassing the majority of the stomach. So not only do we decrease the calories that you take in, but you also decrease the absorption. There's just a picture representation here. I really like this operation for patients who have reflux, because if you can see, the majority of the gastric acid is made in the lower part of the stomach. And when you have reflux, it refluxes back up into the esophagus. With a gastric bypass, you see that the gastric acid can't get back up to the esophagus. So if you have gastric reflux and it's significant, this is a better choice of an operation than the gastric sleeve. Also for diabetes, there's better resolution with the gastric bypass than with the gastric sleeve. Now here are advantages, again, rapid initial weight loss. You do have the dumping syndrome. The dumping syndrome, there's a lot of different concepts of what that is, but truly it's a metabolic situation where the blood sugar drops too low. So if we eat foods that are higher in sugar or fat, it goes into that first part of the small intestine, but it hasn't been broken down by the digestive enzymes. So the body doesn't know how to react to it. We get sweaty, we get hot, you feel like you want to pass out or vomit. And so it keeps you away from eating those foods that maybe are not so great for our weight. It is reversible, but I said most operations don't need to be reversed. Very safe operation. Disadvantages, small, the stomach, the cutting and stapling, potential leak risk, which is very low, vitamin deficiencies. But if you take your vitamins, you're going to be fine and unable to perform a full endoscopic exam. Now, there's risks and complications for the sleeve and bypass because they're similar. Minor things like manageable pain, Nobody ever said, oh, this was so horrible. I wish I never had my operation. It's very manageable. You can have nausea from the anesthesia, very common, but we treat you with medications to prevent that. Lack of appetite, which is a great thing, as long as you remember to eat. Gas pains for the first 24 hours or so. Wound infections are very low rate. Stenosis could require endoscopic interventions or hernias that we need to fix down the road. Major issues are things like gastric leak, blood clots, pneumonia, and small bowel obstruction. These are things that occur very infrequently. We have all kinds of tips and tricks to avoid them, identify them, and if they occur, to treat them. Other operations that are coming into mainstream that we may potentially use on a select basis are things called the SADI, which is kind of like a sleeve and bypass, but a little bit different combined. The one anastomosis, gastric bypass. Magnetic anastomoses are new surgical technology that may be coming in the realm of surgery. And then robotic technology. Robotic technology is adding a component to surgery. Like I said, I perform the operation myself, but through the assistance of a robot, which increases the precise nature of the operation. So that may be used in your surgery as well. But I assure you, it's me that's performing the operation. Here's the great slide. This talks about how all these comorbidities improve. Respiratory dysfunction like sleep apnea. If you wear that CPAP mask, there's a good chance you won't need that after about 2 to 3 months. The blood pressure gets better, the diabetes gets better, especially if it's recently diagnosed under 5 years. But even patients who have been diabetic for a long time, especially type 2 diabetes, tend to either come down on their medication or they get off their insulin altogether. Urinary stress incontinence gets better, meaning the leaky bladder goes away. Reflux gets better, especially with the bypass, sometimes eliminated completely. Menstrual regularities can get better because of PCOS improving. Cholesterol gets better, arthritis gets better, even heart dysfunction gets better. Like I said, it sounds too good to be true, but talk with our patients and you'll see how successful these operations are. The most common thing people say is, I wish I would have done this sooner. So we're glad you're here to consider moving forward. This is an article that talked about how bariatric surgery even improves the risk of being diagnosed with cancer, because we know that there is not a causative relation, but a relationship between obesity and cancer. This talks about the weight loss associated, and there's so many applications now, especially through the Michigan Bariatric Surgery Collaborative. I have a web page at the end for you that you can type in what your weight is, what are your comorbidities, and it'll tell you what you can expect as far as weight loss goes. We know that the SADI and bypass have better weight loss than the sleeve, than the band, and we'll talk about expected weight loss for you, but you can look online through the American Metabolic, ASMBS, American Society for Metabolic and Bariatric Surgery is our national organization. I'm very involved in this. I give a lot of talks for them. I chair a number of the committees. I was the president of the foundation for that society as well. And if you go to asmbs.org, there's a patient portal, which has all kinds of information for our patients as well, if you want more information. And finally, I want to just talk about our program at the Bariatric Surgery Institute. Preoperative preparation is key. You've taken the step, you're looking into having weight loss surgery. We do a mandatory pre-surgical class, which talks about all the things that are necessary to have success after bariatric surgery. Postoperative education, we continue to stress this in the office. You'll see Jenny, you'll see myself, you'll see our other office staff. We do regular monthly support groups. This says quarterly, it's monthly support groups. We do this long term. We have great support online and lifetime follow-up. I want to see you forever, because there may be times where the weight may start creeping up, or maybe the reflux is coming back. And we have so many options to help you continue your success. And we want to see you regularly. It's important we check your lab work, you're doing your supplements, and we're here to support you all along the way. Some people think they're going to be on liquids for the rest of their lives. It's not true. Within 2 weeks, you're on soft foods at stage 4, and regular foods, we progress this pretty quickly. The results, just want to show you some of our patients. Lisa had great success. Her highest weight was almost 300 pounds. She was down to 145. Mary and Damon, they were a couple we operated also. And you see them here before surgery, and now you see them at their wedding day and then on their anniversary. hundreds of pounds down, each of them, and I congratulate them. Sal was over 430 pounds, dropped half his weight to 208 pounds. He was on insulin and lost his weight quickly. Kim had this leave, and at her highest weight was 314. Her surgery weight was 287, then down to 160 pounds. These are real life examples. We've got all kinds more on our Facebook. I always love this story of Stephanie. She is a nurse. She was 437 pounds prior to surgery. She had metabolic syndrome, hypertension, borderline diabetes, high cholesterol. And the sad story, she could not afford airfare to her grandfather's funeral because they wanted her to buy 2 tickets. And we couldn't do that. She lost 253 pounds and she was jumped out of an airplane. Just amazing story. From 400 and something pounds to jumping out of an airplane. Amazing. So in order to get ready for surgery, there's a couple things that need to be done. This is all dependent on your insurance. We're trying to keep this as easy as possible. If your insurance requires 2, 3, 6 months, some even 12 months of documentation prior to your surgery, we're going to help you in that process. We can work with either your family practitioner or you can see us in the office to make sure we get the documentation necessary to satisfy your insurance criteria. And this is just one of the forms we may give you in order to get that done. Common questions, you're in the hospital usually about 2 days, sometimes 1 day. Going back to work depends on how your physical job is, anywhere from a week to 2 months. We don't want you lifting anything heavy for the first 6 weeks. Which procedure is right for you? Hopefully, so you got some idea of what we talked about today, but we're going to work with you, both Jenny and myself, to decide what is the right operation for you. As far as being scheduled for surgery, there are some criteria and things that we need to do prior to the operation. The quickest I've gotten somebody into surgery was about 3 to 4 weeks. Takes usually about a couple months, depending on what your insurance requires. The staples that we use for our surgery, some people say, what happens to those? Well, they're tiny, first of all. But they stick around forever. They're titanium. They don't set off any alarms at the airport or anything like this. So we say 200 years down the road, there's a pile of dust and a pile of staples. The extra skin. Now, this is something also I have in my practice. I perform body contouring and skin removal surgery. I do other cosmetic operations like breast lift, breast augmentation. So when you lose the weight and you've got some of that sagging skin, we can help you. Usually that's about 1.5 years after surgery, and we'll take you through that. And then it basically is a skin removal covered by insurance. Some of the parts are, and some aren't. We'll talk about that later, but you've got some time for that. Other resources, we've got a couple of Facebook pages, Carl Bariatric Pesta, you can search that and join. Slimming Surgery Superstars is a private page for our patients. You just have to answer a question or two on there and we'll get you registered. But that's where a lot of our resources are online. Patient testimonials, information about our support groups. We broadcast our support groups live on Facebook Live. I talked about asmbs.org is our national organization that has a patient portal. And the Michigan Bariatric Surgery Collaborative, or michiganbsc.org, is another great online resource that has some patient information. You can plug in your data and it'll let you know about your risk of comorbidity resolution and your weight loss and all types of things like that. So I want to say thank you very much for tuning in. I'm excited to work with you, and I look forward to all the great things that come with bariatric surgery. Thank you for taking the time to listen in. And if you have any other questions, give our office a call. Next steps for you are just to let Jenny know at the office that you're ready to proceed. If you have more questions before that, of course, let us answer them for you. I wish you the best success in your weight loss journey, and we look forward to being a part of that. Take care.